All right, let's just jump right in. Welcome to This Explainer. Today, we're completely bypassing the basic foundational stuff. You know that, right? Instead, we're going to focus strictly on the really granular physiological details and, honestly, those incredibly complex decision boundaries. We're looking at this from a peer-to-peer perspective, analyzing exactly where subtle, almost hidden variables completely shift patient management. Look, if you're making high-stakes clinical decisions, you already know that textbook algorithms kind of blur in real life. So that's exactly what we're going to untangle today. So here is our clinical rounding list for This Explainer. We're looking at AUB diagnostic forks, adnexal mass stratification, cervical cytology during pregnancy, and finally, clinical reconciliation and variance. Let's get to it. Module 1, AUB diagnostic forks and endometrial biopsy thresholds. We're starting off by mapping the exact thresholds where a management pathways strictly diverge. Okay, so the absolutely crucial first step here is establishing our framework by separating structural etiologies from non-structural ones. We do this using the PALM-COININ acronym. The PALM side, the structural causes, are the things you can generally visualize or palpate, right? Polyps, adenomyosis, leiomyomas, and malignancy. Then, COIN isolates the systemic or non-structural issues: coagulopathy, ovulatory dysfunction, endometrial factors, iatrogenic causes, and the not yet classified bucket. Now, understanding this division is just step one, but knowing exactly when to aggressively screen for the M in PALM, malignancy, well, that's where things get tricky and where clinicians often stumble. Now look at this strict age risk decision boundary for an endometrial biopsy or EMB. If a patient is over 45 and has any abnormal uterine bleeding, that mandates an immediate biopsy, no questions asked. And for postmenopausal women, literally any bleeding at all, or an endometrial stripe of 4 millimeters or greater, triggers that exact same mandatory pathway. But what about the younger cohort? Well, for patients under 45, we restrict immediate EMBs strictly to those with AUB who also have risk factors for unopposed estrogen. We're talking severe obesity, chronic anovulation like PCOS, or patients who just have persistent bleeding that isn't responding to medical management. Let's actually look at how a specific clinical variance disrupts these standard algorithms. Imagine you have a 38-year-old patient. Your gut instinct might tell you, hey, she's way too young for endometrial carcinoma, and maybe you just order an ultrasound or try oral contraceptives. But wait, her BMI is 42. You have to remember that all that peripheral adipose tissue is just constantly converting androgens to estrone, literally bombarding her endometrium with unopposed estrogen. Delaying a malignancy screening here based purely on her age, that is a massive hazard. The choice architecture here absolutely forces an immediate EMB. Moving right along to Module 2, pre- versus postmenopausal adnexal mass stratification. Let's see how sonographic and biomarker data builds a really strict decision matrix. So, before we even think about looking at labs, we have to identify these high-risk acoustic metrics on a transvaginal ultrasound. When you see solid mass components, thick septations, multilocular architecture, or associated ascites, major red flags should be going up. Plus, any complex or solid mass larger than 8 centimeters carries a huge risk profile. These specific acoustic signatures are screaming epithelial ovarian carcinomas or germ cell tumors, and they actively steer us far away from diagnosing a simple, benign functional cyst. This brings us to a really subtle decision boundary: the clinical utility of serum CA-125. Now, in premenopausal patients, CA-125 has terribly poor specificity. It gets falsely elevated by super common, benign inflammatory conditions, things like endometriosis, leiomyomas, or a tubo-ovarian abscess. But flip to postmenopausal patients, and it's a completely different story. Without that normal cyclic menstrual inflammation, CA-125 suddenly has a massive positive predictive value. A level over 35 units in a postmenopausal woman, that is a glaring, blinking warning sign. Let's actually test this boundary with a classic presentation that honestly traps a lot of unwary clinicians. We've got a 58-year-old postmenopausal woman. She's completely asymptomatic. You do an ultrasound and she has a 4-centimeter unilocular simple cyst. Acoustically, it looks totally benign, right? No solid components, 0 septations, but her CA-125 is 180 units per milliliter. So what's your next step? Do you just rely on that reassuring ultrasound and say, we'll monitor it? Absolutely not. The raw biomarker data totally overrides the reassuring acoustic metric here. A postmenopausal pelvic mass combined with an elevated CA-125 over 35 is an absolute non-negotiable indication for direct surgical referral. You bypass serial ultrasound monitoring entirely. Dictating immediate surgical exploration parameters is literally the only correct choice here. Understanding and validating this specific choice variance is what saves lives. All right, Module 3, ASCCP Cervical Cytology Stratification and Pregnancy Exceptions. Let's dive into cervical dysplasia algorithms, especially those strict deviations we have to make during gestation. Okay, so here is the baseline dysplasia cascade for non-pregnant patients. It sharply delineates our two main pathways. For low-grade, somewhat ambiguous changes like ASCUS, we trigger reflex HPV DNA testing. If that high-risk HPV comes back positive, then we proceed to colposcopy. But for high-grade squamous intraepithelial lesions, HSIL, we skip the HPV testing entirely. HSIL demands an immediate diagnostic excision via LEEP, or at the very least, an immediate colposcopy. But what happens when our dysplasia patient is pregnant? Well, a diagnostic colposcopy is perfectly fine. In fact, it's necessary to rule out invasive cervical cancer. However, aggressive endocervical sampling, like an ECC, and routine excisional procedures like a LEEP or cold knife cone, are strictly contraindicated. Why? Because the highly vascularized pregnant cervix makes the risk of severe hemorrhage and subsequent pregnancy loss just catastrophic. Biopsies are strictly reserved only for lesions that are highly suspicious for frank carcinoma. Check out this clinical variance box. It perfectly shows how to navigate this exact trap. You have a 26-year-old at 14 weeks gestation, and her PAP shows HSIL. The colposcopy confirms a high-grade transformation zone. Now, the non-pregnant algorithm would be screaming for a LEEP or an ECC right now, but the choice architecture in pregnancy forces expert colposcopic observation. You have to defer those excisional traps and safely reevaluate the patient in the postpartum period. Finally, Module 4, Clinical Reconciliation and Trot Variance. Let's pull this all together. So, we're going to systematically catalog the parameters that are most frequently missed in high-stakes clinical environments. These are your cognitive disruptors, the really common clinical errors that lead straight to adverse outcomes. First, do not order a routine CA-125 for a simple cyst in a young, asymptomatic woman. You'll just end up chasing false positives from endometriosis. Second, never treat anovulatory abnormal bleeding with an empiric ablation without doing a biopsy first to rule out hyperplasia. Third, do not rely purely on a negative ultrasound to reassure a postmenopausal woman with vaginal bleeding. In those patients, bleeding is cancer until proven otherwise with tissue sampling. And finally, as we just discussed, never ever execute an ECC on a pregnant cervix. Okay, let's really put your skills to the test with an integrative scenario that forces you to balance competing surgical, cytological, and histopathological priorities. Imagine a 46-year-old female presenting with menometrorrhagia, heavy irregular bleeding. She has a 9-centimeter complex multilocular left adnexal mass with ascites. But her CA-125 is completely normal. So when your raw biomarker data is super reassuring, but your acoustic data is blaring alarms, which diagnostic priority dictates your immediate next step? Let's break it down. First, she's over 45 with AUB. That alone demands a mandatory endometrial biopsy. Second, the mass is over 8 centimeters, it's complex, and there's ascites. That structural acoustic risk mandates immediate surgical evaluation. But what about that normal CA-125? You literally ignore it. CA-125 has a notoriously poor negative predictive value for non-epithelial tumors, like germ cell or sex cord stromal tumors. So the resolution completely supersedes that falsely reassuring lab value, demanding immediate, combined surgical staging and endometrial sampling to rule out concurrent primary malignancies. As a clinical consultant, I want to leave you with this final provocative thought to take back to your practice. When your raw biomarker data directly conflicts with the structural reality right in front of you on the ultrasound screen, which algorithm are you going to trust with your patient's life? Thanks for joining me on this explainer. Keep questioning those boundaries, and we'll see you next time.